Welcome to Pediatric Case Review. Today's lecture focuses on bacterial tracheitis, a life-threatening pediatric emergency that requires prompt recognition and management. This condition, though rare, can rapidly progress to complete airway obstruction. Throughout this presentation, we will explore the clinical features, differential diagnosis, pathophysiology, diagnostic approach, and evidence-based treatment strategies. By the end, you should be confident in identifying bacterial tracheitis early and implementing appropriate management to prevent serious complications. Let's begin our comprehensive review. Question 1 addresses clinical presentation. A 5-year-old child presents to the emergency department. The patient has a 1-week history of upper respiratory infection symptoms, including runny nose and cough. Over the past 12 hours, the child developed high fever up to 39.5 degrees Celsius, appears toxic and ill, has inspiratory stridor, subcostal and intercostal retractions, and is producing copious thick purulent secretions. The child received nebulized racemic epinephrine and intravenous dexamethasone with minimal improvement. What is the most likely diagnosis? Option A, viral croup. Option B, bacterial tracheitis. Option C, epiglottitis. Option D, foreign body aspiration. The correct answer is B, bacterial tracheitis. This case demonstrates classic features of bacterial tracheitis following a viral upper respiratory infection. The key distinguishing features include the toxic appearance, high fever, copious purulent secretions, and most importantly, the poor response to standard croup therapies including steroids and racemic epinephrine. Bacterial tracheitis often follows a biphasic course, initial viral symptoms followed by acute bacterial superinfection. This child requires immediate attention to airway management and prompt initiation of broad-spectrum intravenous antibiotics covering Staphylococcus aureus and other common pathogens. Question 2 focuses on differential diagnosis. A 3-year-old child presents with a 2-day history of barky cough and stridor. The child is afebrile with a temperature of 37.2 degrees Celsius and appears well, playful, and non-toxic. After receiving a single dose of dexamethasone 0.6 milligrams per kilogram and nebulized racemic epinephrine, the stridor resolves completely and the child improves significantly. Which clinical feature would most strongly suggest bacterial tracheitis instead of viral croup? Option A, age 3 years. Option B, positive response to croup therapy. Option C, toxic appearance with high fever and purulent secretions. Option D, nighttime worsening only. The correct answer is C, toxic appearance with high fever and purulent secretions. Viral croup typically responds well to corticosteroids and nebulized racemic epinephrine, as demonstrated in this case. In contrast, bacterial tracheitis is characterized by a toxic appearance, high fever often exceeding 39 degrees Celsius, and copious thick purulent tracheal secretions that obstruct the airway. Children with bacterial tracheitis fail to improve with standard croup treatments. The age of the patient and nighttime worsening can occur in both conditions, making them unreliable distinguishing features between viral croup and bacterial tracheitis. Question 3 continues our differential diagnosis discussion. A 6-year-old child presents with acute onset of high fever to 40 degrees Celsius and progressive stridor over 6 hours. On examination, the child has no drooling, is able to lie supine comfortably, has a hoarse voice, and demonstrates a productive cough with thick secretions. The child appears toxic but can swallow saliva without difficulty, which finding most strongly points away from epiglottitis and toward bacterial tracheitis. Option A, drooling. Option B, tripod posture. Option C, ability to lie supine without drooling. Option D, thumb sign on lateral neck radiograph. The correct answer is C, ability to lie supine without drooling. Epiglottitis classically presents with the 4 Ds: drooling, dysphagia, distressed appearance, and preference for sitting in the tripod position leaning forward. Children with epiglottitis cannot lie supine comfortably due to worsening airway obstruction in that position. In contrast, children with bacterial tracheitis usually do not have drooling, can swallow their secretions, and can lie in any position including supine. The presence of cough and purulent secretions also favors bacterial tracheitis, as epiglottitis typically presents without cough. Question 4 examines pathophysiology. A 7-year-old child was diagnosed with influenza A infection 5 days ago and was recovering at home with symptomatic treatment. Today, the child acutely deteriorated with new onset high fever, respiratory distress, stridor, and thick secretions requiring emergency department evaluation. The parents report the child was improving yesterday. What is the most likely pathophysiologic mechanism for this acute deterioration? Option A, primary allergic airway edema. Option B, secondary bacterial invasion of damaged tracheal mucosa leading to inflammation, edema, and mucopurulent exudates. Option C, autoimmune vasculitis. Option D, previously undiagnosed congenital subglottic stenosis. The correct answer is B, secondary bacterial invasion of damaged tracheal mucosa leading to inflammation, edema, and mucopurulent exudates. Bacterial tracheitis typically follows a biphasic pattern. Initial viral infections, particularly influenza A, respiratory syncytial virus, or parainfluenza, damage the tracheal epithelium and impair local immune defenses. This creates an opportunity for bacterial pathogens to invade the damaged mucosa. The subsequent bacterial infection triggers intense local inflammation, producing thick mucopurulent secretions, pseudomembrane formation, and severe airway edema. This pathophysiology explains the characteristic clinical course of initial viral symptoms followed by acute bacterial deterioration with airway compromise. Question 5 addresses microbiology and etiology. A 4-year-old child is diagnosed with bacterial tracheitis based on clinical presentation and requires intubation for airway protection. The medical team performs bronchoscopy and obtains tracheal secretions for culture. While awaiting final culture results, which organism is statistically the most common causative pathogen in pediatric bacterial tracheitis? Option A, Staphylococcus aureus, including methicillin-resistant strains. Option B, Moraxella catarrhalis. Option C, Pseudomonas aeruginosa. Option D, Mycoplasma pneumoniae. The correct answer is A, Staphylococcus aureus, including methicillin-resistant Staphylococcus aureus. Staphylococcus aureus is the most frequently isolated pathogen in bacterial tracheitis, accounting for approximately 40 to 60% of cases. Both methicillin-sensitive and methicillin-resistant strains can cause disease. Other important pathogens include Streptococcus pneumoniae, Moraxella catarrhalis, Haemophilus influenza type B and non-typable strains, and Streptococcus pyogenes. Less commonly, Pseudomonas aeruginosa and anaerobic bacteria may be isolated. This microbiologic profile guides our empiric antibiotic selection, which must include coverage for methicillin-resistant Staphylococcus aureus. Question 6 explores examination findings. A 5-year-old child presents with 3 days of worsening respiratory symptoms. On physical examination, you note high fever of 39.8 degrees Celsius, both inspiratory and expiratory stridor, severe hoarseness affecting phonation, visible subcostal and intercostal retractions, thick purulent secretions at the mouth, and no drooling. The child appears toxic and fatigued but remains alert. Which examination triad best characterizes bacterial tracheitis? Option A, afebrile, well-appearing, barky cough. Option B, high fever, toxic appearance, purulent secretions. Option C, drooling, tripod posture, muffled voice. Option D, wheezing only without stridor. The correct answer is B, high fever, toxic appearance, and purulent secretions. This triad represents the hallmark clinical features of bacterial tracheitis. Children typically present with high fever exceeding 39 degrees Celsius appear toxic and severely ill and produce copious thick purulent secretions that can obstruct the airway. Stridor is typically biphasic, meaning both inspiratory and expiratory components are present, differentiating it from viral croup, which usually has only inspiratory stridor. The absence of drooling is an important distinguishing feature from epiglottitis. Retractions, tachypnea, and respiratory distress severity correlate with the degree of airway obstruction. Question 7 discusses radiographic findings. A clinically stable child with suspected bacterial tracheitis undergoes lateral neck radiography as part of the diagnostic workup. The emergency physician carefully reviews the imaging. Which specific radiographic finding on lateral neck radiograph most strongly supports the diagnosis of bacterial tracheitis? Option A, steeple sign only. Option B, thumb sign. Option C, irregular tracheal mucosa with hazy air column, described as the candle dripping sign. Option D, radio-opaque foreign body at the thoracic inlet. The correct answer is C, irregular tracheal mucosa with hazy air column, known as the candle dripping sign. This finding reflects the thick mucopurulent exudates and pseudomembranes adherent to the tracheal wall, creating an irregular, shaggy appearance of the tracheal air column. The steeple sign, showing subglottic narrowing, is nonspecific and commonly seen in both viral croup and bacterial tracheitis. The thumb sign indicates an enlarged epiglottis characteristic of epiglottitis. However, It is important to note that radiography should never delay definitive airway management in unstable patients. Clinical diagnosis remains paramount. Question 8 addresses diagnostic investigation. A child is suspected of having bacterial tracheitis based on clinical presentation, but remains hemodynamically stable with oxygen saturation of 94% on room air and no immediate signs of complete airway obstruction. The pediatric team considers diagnostic confirmation. What is the gold standard diagnostic test to definitively confirm bacterial tracheitis when clinically appropriate? Option A, throat swab culture. Option B, neck ultrasound. Option C, direct laryngoscopy or flexible bronchoscopy. Option D, rapid antigen detection test. The correct answer is C, direct laryngoscopy or flexible bronchoscopy. This procedure allows direct visualization of the inflamed trachea, revealing characteristic findings including erythematous and edematous tracheal mucosa, thick mucopurulent secretions, and pseudomembranes adherent to the tracheal wall. Bronchoscopy serves dual purposes: diagnostic confirmation and therapeutic intervention. The procedure enables suctioning of thick secretions to relieve obstruction and collection of specimens for culture and sensitivity testing. However, bronchoscopy should only be performed in controlled settings with experienced personnel and equipment ready for emergency intubation if needed. Question 9 focuses on antibiotic management. A 6-year-old child is diagnosed with bacterial tracheitis in the emergency department. The child appears toxic, has high fever, stridor, and requires admission to the pediatric intensive care unit. The patient has no known drug allergies and normal renal function. Tracheal cultures have been obtained, but results are pending. What is the most appropriate empiric antibiotic regimen for this patient? Option A, oral amoxicillin alone. Option B, oral azithromycin alone. Option C, intravenous ceftriaxone plus intravenous vancomycin. Option D, oral oseltamivir alone. The correct answer is C, intravenous ceftriaxone plus intravenous vancomycin. This combination provides comprehensive broad-spectrum empiric coverage for the most likely bacterial pathogens in bacterial tracheitis. Vancomycin covers methicillin-resistant Staphylococcus aureus, which is the most common causative organism. Ceftriaxone, a third-generation cephalosporin, provides excellent coverage against Streptococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis, and other gram-negative organisms. Alternative regimens include clindamycin plus a third-generation cephalosporin. Once culture and sensitivity results become available, antibiotic therapy should be narrowed to target the specific organism identified, optimizing treatment and minimizing unnecessary broad-spectrum coverage. Question 10 examines airway management. A 4-year-old child with confirmed bacterial tracheitis is being monitored in the pediatric intensive care unit. Over the past 30 minutes, the child has developed progressive hypoxia with oxygen saturation dropping to 85% despite supplemental oxygen, shows increasing work of breathing with fatigue, has paradoxically decreasing stridor suggesting critical airway narrowing, and demonstrates poor air entry bilaterally on auscultation. What is the most appropriate next step in management? Option A, administer another dose of nebulized racemic epinephrine only. Option B, obtain lateral neck radiograph first. Option C, proceed with controlled endotracheal intubation by the most experienced available team. Option D, discharge home with oral antibiotics. The correct answer is C, proceed with controlled endotracheal intubation by the most experienced available team. This child demonstrates clear signs of impending respiratory failure and imminent complete airway obstruction. Decreasing stridor is an ominous sign indicating critical airway narrowing. Progressive hypoxia, increased work of breathing with fatigue, and poor air entry are indications for immediate definitive airway management. Intubation should be performed by the most experienced clinician available, ideally in a controlled environment like the operating room or intensive care unit with backup equipment ready. An endotracheal tube 1 to 2 sizes smaller than age appropriate should be selected due to airway edema and narrowing. Following intubation, intensive care monitoring with frequent endotracheal suctioning is mandatory. Question 11 addresses complications. A 5-year-old child was successfully intubated for bacterial tracheitis and is now recovering well in the pediatric intensive care unit after 72 hours of appropriate antibiotic therapy and supportive care. The parents ask about potential complications of this condition. Which immediate life-threatening complication was most concerning at the time of initial presentation before airway management was secured? Option A, complete airway obstruction leading to hypoxic cardiac arrest. Option B, acute otitis media. Option C, dehydration only. Option D, viral myocarditis. The correct answer is A, complete airway obstruction leading to hypoxic cardiac arrest. This represents the most immediate life-threatening complication of bacterial tracheitis and is the primary reason why early recognition and aggressive airway management are critical. The thick mucopurulent secretions and pseudomembranes can rapidly progress to complete tracheal obstruction, resulting in severe hypoxia, respiratory arrest, and subsequent cardiac arrest if not promptly addressed. Other serious complications include acute respiratory distress syndrome, aspiration pneumonia, pneumothorax, septic shock, toxic shock syndrome, and post-intubation tracheal stenosis. The mortality rate, historically as high as 20%, has decreased significantly with modern aggressive airway management and appropriate antibiotics. Question 12 discusses treatment duration and level of care. A child with bacterial tracheitis has shown significant clinical improvement after 72 hours of intravenous antibiotic therapy. The fever has resolved, secretions have decreased substantially, and the child was successfully extubated. Tracheal culture results are now available showing Staphylococcus aureus sensitive to multiple antibiotics, allowing de-escalation from empiric broad-spectrum coverage. What is the recommended total duration of antibiotic therapy for uncomplicated bacterial tracheitis? Option A, 3 to 5 days. Option B, 7 days. Option C, 10 to 14 days. Option D, 30 days. The correct answer is C, 10 to 14 days total duration. Current evidence-based guidelines recommend a complete antibiotic course of 10 to 14 days for bacterial tracheitis, though no formal randomized controlled trials have definitively established optimal duration. Treatment typically begins with intravenous antibiotics during the acute phase. Once the patient demonstrates a significant clinical improvement with resolution of fever, decreased secretions, and ability to maintain the airway without intubation, transition to oral antibiotics can be considered to complete the full course. Most patients require admission to the pediatric intensive care unit, particularly those requiring intubation. Close monitoring is essential throughout treatment. Before we conclude, I want to invite you to join our exclusive Pediatric Case review community on Patreon. As a member, you will gain access to all our educational videos systematically organized by organ system and specialty, making it easy to find exactly what you need for your studies or clinical practice. Additionally, all presentation slides used in our videos are available as downloadable high-resolution images, perfect for reviewing content, practicing questions, and reinforcing your learning. If you are interested in accessing this comprehensive resource library and supporting our educational mission, please comment below on this video and we will send you detailed information about membership options and subscription process. Thank you for watching this comprehensive lecture on bacterial tracheitis. Let's review the key takeaways. First, recognize bacterial tracheitis early by identifying the classic triad: high fever, toxic appearance, and purulent secretions following a viral upper respiratory infection. Second, remember that failure to respond to standard croup therapies is a red flag for bacterial tracheitis. Third, prioritize airway management above all else, as airway obstruction is the primary cause of mortality. Fourth, initiate broad-spectrum antibiotics immediately, covering methicillin-resistant Staphylococcus aureus and other common pathogens. Please follow Pediatric Case Review for more evidence-based educational content. If you have questions, comment below and we will respond. Stay curious and keep learning.